I just want to welcome everyone this evening to another Learn from Home webinar presented by MedShape. This one is entitled Excelling in NiTiNOL Fusion Solutions for Foot and Ankle Applications. My name is Kat Smith. I'm the Director of Marketing, and just want to thank everyone for joining us this evening. Just a few housekeeping items before we get started. We will have a Q&A at the end of the presentation. If you have a question, please submit your question in the Q&A chat box. It should be located in the toolbar either at the top or bottom of your screen. The speakers will then get to all the questions at the end. Second, this webinar is being recorded, so if you do want to go back and rewatch or share with colleagues, you will receive a link from us with the recording in the next few days. All right, with that, I'm very excited to introduce our faculty panel for this evening. They have experience not only with MedShape's NiTiNOL staples, but also many years experience with NiTiNOL stapling in general for foot and ankle. And I think that will help lend some additional color to the conversation this evening. Our first presenter is John Kwon from Harvard Medical in Boston, Massachusetts. Second presenter is Craig Lareau from New England Orthopedic Surgeons in Springfield, Massachusetts. Then we have Zachary Ritter from UPMC Susquehanna in Williamsport, Pennsylvania. And then finally, Jeffrey Seybold from Twin Cities Orthopedics in Edina, Minnesota. And just a quick run through of the agenda for this evening. They're going to start by covering the current state of fusion devices, what are some of the potential limitations, why the DynaClip Forte, how does the Forte address these limitations, and with that discussing the design rationale, how does it perform, we're looking at the biomechanics, how do you use it, they'll discuss the surgical technique, and then finally, where to use it. And here they'll be talking about or sharing some various case examples. All right, with that, I'm going to turn it over to Dr. Kwon to kick things off.
Thanks, Kat. Thanks for having me. I'd like to thank MedShape for allowing us to talk a little bit about staples. We want something that offers torsional and translational stability, something that offers compression, is easy to use with a minimal learning curve and simple instrumentation. And traditionally, fusion of various foot and ankle joints have been performed using screws or other plate constructs. In regards to plates, plates have some limitations. While plates are good at rotational control, they offer no inherent compression. Surgeons have to rely on surgical techniques to achieve maximal compression before application. And really, when we put a screw through a dynamic compression hole, there's very little additional compression achieved by doing that. Furthermore, there's no mechanisms for sustained compression, so that if there's bone resorption or loosening from non-compliance or whatever, then all compression achieved in the OR is lost with plates. What about screws? So screws are obviously simple to use, they're inexpensive, and they afford good initial compression, but they have some limitations as well. They offer very little rotational control, they have poor bending rigidity, and in certain joints that we fuse in the foot and ankle, they can be pretty technically difficult to place in the right spot. Screw fixation alone can be challenging and unsatisfying for many joints, including the second and third TMT joints, intercuneiform fusion, or when doing TALONAVICULAR fusion. Now, what about staples? So staples have certainly evolved over the past 30 years, not only in design, but materials and modes of compression. Essentially, we started with static stainless staples, which offered no compression. And then staple design changed to offer compression, for example, by expanding the staple. And as we've developed NiTiNOL, the design and the amount of compression has significantly changed. Now, NiTiNOL has really changed the industry and will continue to do so as it becomes incorporated into more orthopedic implants and devices. The superelastic property of NiTiNOL, which allows for sustained compression, is really advantageous, in particular in two situations. One, where we have bone resorption, which is, of course, a normal part of healing. And two, any situations in which the internal construct is loaded post-surgery before bony union can occur.
Thanks, John. So what does the literature say? This is not just the simple experience from those of us kind of using these implants, you know, what's going to be easier with plates or screws or staples. And there's actually been a few studies that have been put out about the more current staple design that goes through both the biomechanical properties and advantages, as well as what the clinical results are in case series using these staples as opposed to plates or other more traditional forms of fixation. So when looking at staples versus plates from a biomechanical standpoint, there has been a few lab studies, including some of the bench studies performed through MedShape with some of the design of their staples that demonstrate these findings where the NiTiNOL staple allows for better compressive areas as well as a higher compressive load across an osteotomy site or, you know, a laboratory fracture sites, artificially induced fracture sites. And you can see that with the images on the right. Basically, when comparing either two different staple orientations versus a static plate design, once you apply the staple, you're going to get a continued compression across where that manufactured osteotomy is through the material, providing excellent compression, predominantly right under the bridge, but all the way extending even to where the legs of the staple extend through the material. And that's enhanced with certain staple designs or orientation. So whether you're using one staple versus two or two staples in an orthogonal fashion can enhance the mechanical properties of that staple and the amount of compression you achieve across the osteotomy site, as opposed to a plate where once you've locked that plate into position, even if you're applying compression across the osteotomy or fracture sites or whatever surface that you're applying the plate to, once that plate's secured, you've basically maxed out what your compression area is and what that compression load is through the material. And as soon as you start to get some load or resorption of bone, whatever it is at that osteotomy or fusion or fracture site, you've immediately lost whatever compression that you were trying to hold while applying that plate. And so by adjusting the staple design or adjusting the staple orientation, you can take advantage of some of these areas. Clinically, there have been a few staples as well to look at, or a few studies as well to look at how staples compare to either hybrid fixation techniques or more traditional locking plates and screws. And this is a study that was performed by Dr. Ellington and his colleagues in 2018. This was published and basically looked at a large cohort of patients that basically had nearly 100 different patients and about 150 total fusions throughout various areas of the midfoot and hindfoot. And they compared their fusion rates at each of the individual joints when using staples alone versus some sort of hybrid fixation with a staple and screw. And when looking at their various results, and this is one of the primary tables from the study you can see on the screen, the staple fusion rates were basically 95%, which was very comparable to the staple and screw fusion rates. There was no statistically significant difference when using the staples alone versus the staples and screws. And while there were slightly lower fusion rates in a few of the fusion areas with the staples alone, namely the first TMT joint and the navicular cuneiform joint compared to the staple and screw construct, again, those differences were not statistically significant. So the staples definitely demonstrated a high and very favorable accessible fusion rate for some of these areas of the midfoot and hindfoot that can be sometimes a bit tricky to get adequate fixation with more traditional constructs. This is also looked at in a recent study that was published this year by Coughlin's group in Idaho. They basically did the same thing, looked at a number of their different fusions of the midfoot and hindfoot. This was all with traditional locked dorsal compression plating. and they found their overall fusion rate was about 81%, which compared to the literature is pretty on par. But obviously, when comparing this directly with the results of fusion at these same joints when using the staples, obviously from the study from Dr. Ellington had a higher and more advantageous fusion rate when compared with Dr. Coughlin's study here. Fairly similar numbers as far as their total number of joints that were fused, with obviously a little bit lower overall union rate. So going back to the initial problem with how we secure fusions or osteotomies or even fractures with some of this hardware in the foot, clearly staples have demonstrated an advantage over traditional plating and screws in that they can be relatively easy to implant. You can work with the anatomy in a little bit easier fashion. And we'll get to some of the advantages of the Forte staple momentarily. But with the traditional staple designs, there are some problems in that the way that they were designed, there's mechanically weak spots that can result in breakage of the staples, ultimately potentially non-unions or other problems with the bone healing. And this is from the same study by Dr. Ellington in FAI in 2018. And with their results, even with a good fusion rate with the staple construct and using a wider bridge staple for some of their patients, they noted that up to a little over 10% of their patients had a staple break during their post-operative period. Now, clearly this did not compromise the union rate in all of these patients, but definitely demonstrated an inherent weakness with some of the at least older or original staple designs in terms of where these mechanical weak spots may cause problems with the fixation and ultimately leading to a good clinical result.
So this sort of pulls us into the design rationale behind the Forte staple and some of the thoughts the design team has had as this staple was developed and it's gone through mechanical testing. So I'm going to sort of take you through specifically with respect to the Forte, what we're seeing. So if we advance here and we look at sort of I'll say the anatomy of the Forte staple, and this is in comparison to the other 4-leg inline staple that's on the market, the BME Elite. We can see that the Forte allows curvature through the bridge of the staple. And why is that important? Well, imparting the compression through the bridge rather than through the legs, such as the BME inline staple, the design rationale is that in that you're going to get more compression across that near cortex. So if you look at this compression map here and you see that through the bridge compression, we're able to apply not only compression through that cancellous portion of bone, but also along the cortex. And that's all inherently designed in the staple, versus if you look at the BME staple, the compression is through the legs of the implant. And so you're not getting that near cortical compression, which imparts some increased rigidity. The other thing, as we were talking about a little earlier, is Dr. Ellington's study did show the picture of the X-ray with the broken leg. If you've used staples in the past, you'll see that a lot of the failure in current staples on the market comes at the leg, and that's where we're seeing these break. So the design rationale here with the Forte is not only a thicker leg, but compression through the bridge. So if there is going to be a point of failure, it should not be within the leg of the implant, which could help you long term. Looking to compression, compression is something that we all talk about with NiTiNOL devices, right? So that's sort of the big word when it comes down to using NiTiNOL devices, whether it's a nail or a staple from any company. So if we look at the Forte specifically with respect to the inline BME Elite, which is sort of trying to compare apples to apples, we can see onset compression strength versus compression strength after 2 millimeters of resorption. And why is resorption important? Because we know that as bone heals, there's going to be some resorption. So if we understand the fact that bone is going to resorb as it heals, and we understand the importance of compression, we can therefore understand the importance of this strength in the BME Forte, or sorry, the DynaClip Forte versus the BME Elite. We know that that compression alone does not impart healing. Really, rigidity is what allows healing to occur. You know, we can't, I always tell people, you know, we can't make bone heal faster, but we can certainly try to prevent it from healing more slowly. Bone can only accept about 2% strain before it fails. And so as bones heal, it can only accept 2% strain before that healing delays. So as resorption occurs, we're allowing more laxity and more instability. So with that continued compression force, and we see that more dominantly in the DynaClip Forte, we're able to impart continued rigidity and strength to that union site. And in that, hopefully, we're going to be seeing more consistent unions at consistent points in time. Here too is going back to the strength of the device, and again where we look at the site of failure. If we look at competing staples on the market, we can see that the stress occurs in the legs. And why is that? Well, we know, as I showed you a couple slides ago, that's because the compression is generated through the legs and not through the bridge. So when you have failure, you will have failure in the legs. Versus the DynaClip Forte, that stress is distributed evenly across the bridge through the legs. So if we have a point of failure, it should be in the bridge, which makes it an easier device to remove. Then if we look at rotational stability, you can see the benefit of comparing a 26 by 20 Forte versus a 30 by 20 versus a single 20 by 22 two-leg implant or DynaClip implant. Why is this important? Well, this is important in some instances where you only have enough anatomy perhaps to use one implant, or you only want to use one implant. If we're able to limit that rotational instability and we're only able to use a single implant and it still imparts good compression across the arthrodesis site, then not only are we gaining a successful rigid fusion, but we're also doing that in what I would say a relatively minimalistic fashion. So increasing that rotational stability, and then if you were to add on top of that a DynaClip two-leg, that imparts more stability than that. And so again, through all of that, we're increasing rigidity, which decreases the strain on the bone and therefore decreases the chances of non-union or failure. Finally, we've all had patients with irritation from plates and screws. If you look here at the Forte design, it's only about 1.5 millimeters across the top of that bridge. If you think of foot and ankle surgery in general, we know that some of our anatomy has relatively tenuous tissue structures or minimal subcutaneous cushion, although some of our patients have plenty of subcutaneous cushion. You know, in this case, we can see that sort of low profile design along the top of a bone. You can contour the bone to allow the staple to sit even more flat, but there's not that elevated prominence that we would traditionally see with either a big screw head sticking up or conversely a plate or the two combined.
Thank you, Zach. So the Forte offers some convenient features to save both time and cost. You can see here the prepackaged sterile adjustable drill guide, which also can serve as a sizer. Comes with a 3 millimeter drill bit and the locator pins as well. So this, you only need to open one of these regardless of how many Forte staples you use. Additionally, the inserter, which you see there in the lower right, can also be used as a tamp. You pull up on the inserter and slide it to release the staple prior to final impaction. Here's a brief animation. So following your standard joint preparation for fusion, I think it's important, it's not shown in this animation, but to achieve good bony apposition and compression and to maintain that with either a provisional K-wire or you can use a Hinterman or a clamp to compress the joint. Then applying your adjustable drill guide here, and again, using that as a sizer. I like to use K-wires to determine the ideal location for the staple legs. I think there's limited real estate in the midfoot especially, and so you don't want to drill too many holes if you can avoid that. The drill bit, as you can see there, it shows you the length 18, 20, and 22 millimeters to see where you stand as far as the far cortex and to try to achieve bicortical fixation if possible. So this is a nice reusable tool. It's a removal and reload tool. It can be used both for 4-leg Forte staples as well as the 2-leg DynaClip. This, in my experience, is not offered by many of the other competitor companies. It definitely decreases my stress level in the OR. I'm sure we've all had situations where a staple did not impact properly for whatever reason. And once it's sort of off the inserter, in some cases, you're really kind of stuck and you can't reuse it, have to burn another staple. So I think having this at your disposal is a nice thing to have in the toolbox. Sorry. So in terms of size offerings, this shows the 2 Forte current size offerings, the 26 by 20 and the 30 by 20. The 26 millimeters refers to the bridge length and the 20 millimeters is the leg lengths. This also shows the inner leg diameter of 14 millimeters for the 26 millimeter staple and 18 millimeters for the 30 millimeter staple. We see here the bridge width is 5.5 millimeters. As Zach mentioned, the bridge thickness is 1.5 millimeters, and your leg length diameter is 2.5 millimeters, which corresponds to the 3 millimeter drill. So if orthogonal fixation is desired, these are compatible with various 2-leg DynaClip options. I like to use this configuration for first TMT fusion or Lapidus procedures, showing again here, for example, that the 20 by 22 staple would fit with a 26 by 20. You're trying to get the legs of the 2-leg DynaClip within the inner and outer legs of the Forte. So there's multiple indications for using the Forte between midfoot and hindfoot fusion as listed here. I think these work quite nicely in terms of rotational control over the conventional 2-leg staple. We'll present some cases here in a few minutes demonstrating some cases that have been done recently. Additionally, the use of the staple for a first TMT fusion is a promising application. One concern is the leg lengths can be a bit long, especially in the proximal phalanx, but we can talk more about that. So just a few recent cases here. This is a 54-year-old diabetic neuropathic woman who I saw recently. She had had a previous, what was deemed to be a bad foot sprain 5 months before I had seen her, which she was not improving, had diffuse swelling. Was diagnosed with this transverse tarsal Charcot collapse. So I performed a triple arthrodesis in conjunction with a medial column fusion, used a 30 by 20 DynaClip Forte staple for the calcaneocuboid joint, which I think works quite nicely for that indication in terms of rotational control and compression. This is her most recent x-rays at 4 months post-op. I'm pretty conservative with folks, especially in the case of diabetic Charcot arthropathy. And she was kept non-weight bearing in a splint and cast for the first 6 weeks, followed by another 6 weeks in a tall diabetic cam boot, and then transitioned to a brace. Another case of a 58-year-old gentleman. He had a rigid pes plana valgus deformity, as you can see here on his pre-op x-rays, with significant lateral peritalar subluxation and collapse of Meary's line in the lateral view. He had failed bracing and other conservative measures. So he underwent a triple arthrodesis. I did use some two-leg DynaClip staple for the talonavicular joint, and then another DynaClip Forte 30 by 20 millimeter for the calcaneocuboid joint. We let him begin weight bearing on his foot at 6 weeks. And I believe these are also his 4-month x-rays demonstrating good healing of his hind foot. And a third case here demonstrating a 63-year-old woman. She had a remote attempted hallux valgus correction with recurrence, widening of her first and second intermetatarsal angle. She underwent removal of hardware and a Lapidus procedure here. I used both a 4-leg DynaClip 30x20 staple in conjunction with a 20x18 staple. This is an example where I think the compatible 2-leg DynaClip staple that is called for, I was able to use a different staple that worked well for this indication. Again, similar post-op protocol, a little more aggressive with Lapidus, where I let her weight bear, I believe, at 4 weeks. She was getting out of a boot to a sneaker between 8 and 10 weeks. And again, these are her 4-month post-op x-rays here.
Thanks, Greg. A couple more cases we can go over. These are a few other indications or uses of the Forte staple. So this was a 70-year-old gentleman. He was about 2 years status post ORIF of a Lisfranc fracture dislocation, at which point, in addition to the fracture fixation or the Lisfranc fixation, performed a primary second TMT arthrodesis. And he healed uneventfully, but ended up developing some increased midfoot pain over the previous month to me seeing him just recently. Had an x-rays that are shown here, as well as a CT scan, which ultimately demonstrated adequate healing of his second TMT fusion and good alignment through his Lisfranc complex, but progressive post-traumatic degenerative changes, predominantly at his first and his third TMT joint, where he had been having arthritic symptoms with weight-bearing activity as well. And so he underwent removal of his midfoot hardware, did fusions of the first and third TMT joints. The first TMT fusion was accomplished with the DynaClip Forte staple. The third TMT joint was just a standard DynaClip staple, 2-time staple. And he was a gentleman that, despite best efforts to encourage him otherwise, I knew it was going to be immediately putting some weight down on his boot. And so we protected him in a boot with weight-bearing activity for about 6 weeks, tried to keep him to more toe-touch weight-bearing, more for transfers and balance and those sorts of things. And he ended up healing very well, had great early healing at both the first and third TMT joints at 6 weeks, with his radiographs felt comfortable progressing into a supportive shoe and continuing low-impact activity. He's now about 6 months out and doing very well as far as pain relief is concerned. These x-rays were his 3-month post-op x-rays, again, showing at this point already some adequate healing at both the first and third TMT fusion sites. This is a 62-year-old gentleman who had a chronic left flat foot deformity with increasing pain despite orthotics and bracing, other sorts of conservative treatments. Had a relatively flexible flat foot deformity on examination, not a terrible looking Meary's angle. He does have some talonavicular abduction, you can see on the AP foot x-ray. Also had some mildly symptomatic first TMT degenerative joint disease on exam, in addition to his hind foot symptoms, which were pretty well localized around his sinus tarsi and posterior tib tendon. And so he underwent gastrocnemius recession, flat foot reconstruction, which included a medial displacement calcaneal osteotomy, debridement of his posterior tib tendon with an FDL transfer. And then with his residual forefoot supination, wanted to make sure to address that since he had some pre-existing arthritis that was mildly symptomatic at his first TMT joint. We accomplished this with a plantar flexion first TMT arthrodesis. And essentially for that portion of the procedure, I used a 8mm dorsally based allograft bone wedge, impacted that into position in the first TMT joint after prepping the joint and debriding the cartilage, and then secured that with the larger 30mm DynaClip Forte staple. Had a good amount of space between the two inner tines of the staple to fully bridge the allograft and still maintain good compression across that first TMT joint with the more inner tines just within that almost subchondral bone on both sides of the joint. He was, again, immediately touchdown weight bearing in a boot. I typically am pretty conservative with these folks as far as progressing full weight bearing on the foot or even 50% weight bearing, that sort of thing. So typically about 6 weeks that I will hold these patients out, and he was no exception to that. At 6 weeks, radiographically, everything's looking good. Then we'll progress out of the boot or full weight bearing in the boot, and then eventually transitioning into a shoe, typically by about 8-9 weeks post-op. Patients are comfortable enough doing that. Now, I will say, incidentally, this is an update from today. So I saw this patient back in clinic today. He's about 3.5 months post-op. and doing very well clinically and not having any pain, no midfoot pain problems. He had had a little bit of discomfort over his midfoot at the first TMT fusion site as he was progressing back into shoe wear a few weeks ago. And I don't have his updated radiographs today, but he actually had one of the tines of the Forte staple that fractured right about 8 millimeters or so distal to where the bridge is. We actually checked him with the CT scan. Radiographically, things were looking okay. And we got a CT scan on him today that showed he had about 50 to 60% bridging bone already incorporating around both sides of that allograft bone wedge at the first TMT fusion site. So even though there had been a little bit of extra strain on that staple, it seems, with his weight-bearing activity, it was providing enough stability, enough compression, even with the allograft wedge in there, that by 3 months post-operatively, he had demonstrated better than 50% bone bridging and healing across that fusion site. So just does speak to the power of the staple and the stability that it can cause or can provide as we're trying to win that race between bone healing and how well any sort of hardware fixation will secure across a fusion site or a osteotomy. The last case here is an 82-year-old gentleman. This gentleman was about 2 years status post first MTP joint arthrodesis, performed at an outside institution and came in to see me because he was having acute pain that had developed over the dorsal aspect of his hallux. His pain localized fairly well over where his prominent screw head was sitting there. You can see the pocket screw essentially in that plate and screw construct design backing out and starting to sit a little bit more prominently underneath the subcutaneous tissues. He also had a little bit of generalized aching in his first MTP joint that had been bothering him a little bit on and off over the past previous few years. And x-rays were certainly concerning for a non-union at the first MTP fusion site with failure, not only backing out of that crossing screw, but one of the distal screws through the plate you can see. And so we talked about options with him, and his primary concern was the hardware prominence more so than any aching discomfort at his first MTP fusion site. But in talking about some of the symptoms he was having, it didn't make a lot of sense to go in and just take the screw out, especially if one of the other screws had already failed, if he had a non-union that was clearly causing a little bit more strain and instability potentially of the hardware, where we'd just be coming back to take out another screw down the road or having some other hardware issues. So we decided that it would make the most sense to revise his fusion while we're in there and try to, obviously prevent any, not only hardware issues, but difficulties or aching pain from the non-union site itself. And so when deciding what to implant here to revise the fusion, decided to use the Forte staple in this case for a couple of different reasons. One was obviously the hardware irritation he experienced before. He didn't have a lot of soft tissue coverage over the previous fusion site. And so the low profile aspect of the staple, I think, was an attractive feature here. Also with the added compression and the stability of the staple as opposed to some alternative construct designs, especially when dealing with bone that already had hardware placed and a little bit older bone that was a bit weaker and osteopenic, that having the added compression from the staple and the stability from the staple might improve our union rate here and allow for a little bit safer early weight-bearing activity. Again, this is a gentleman that at 82 years old didn't want to have an option where he was going to have to stay off his foot for very long and be able to mobilize relatively safely. And then the other concern was, if indeed he doesn't heal this fusion, going back in a second time with the revision case, what happens with it, clearly he was getting around reasonably well with an asymptomatic non-union the first time, or with a minimally symptomatic non-union the first time around. And so even if this doesn't heal, what happens to it? And as alluded to with the benefit of the Forte design and staple design in this case, if there's going to be failure of this, maybe one of the tines breaks and, at least that the staple is unlikely to back out or cause any hardware prominence in that regard. Or, with where most of the compression is being able to apply, or where a lot of that compression applies through the bridge, if the bridge fails, again, you're still not going to be dealing with a screw that's backing out and suddenly becoming prominent. So for a lot of those reasons, I thought the Forte here would work fairly well. You can see on the lateral view at the proximal phalanx that the tines are a little bit long and extend beyond the bone. you know, obviously looks a little bit worse than it is. The amount of prominence there is only a measure, a couple of millimeters. And while we were putting in the staple, wanted to make sure that it didn't feel prominent. It, you know, certainly weren't able to feel the tines underneath the plantar skin. There wasn't any crepitus with moving his FHL tendon passively. And on exam, he's done just fine with that post-operatively too. So it didn't seem to be too much concern. And so we left the tines a little bit prominent and thought that this would hopefully be a good construct for him here down the road. He was allowed to immediately touch down weight bear in a boot. And ultimately he was walking fully on the forefoot after the first couple of weeks already. And then 6 weeks post-op, these are his radiographs here. We haven't seen him back quite yet since that time. This is a relatively recent case, but he was transitioning back into a regular shoe. And clinically, he's done just fine. He hasn't had any increased pain problems. He's very happy with the lack of the hardware prominence as well already at this point, now about 2.5 months post-operatively.
Great, thank you. So the first case that I'm going to discuss is a 60-year-old female. She is one of the environmental services employees at our hospital. You can see that she has this progressive collapse of the foot here, a little increased talonavicular uncovering, definitely some increased talar pitch, some degenerative disease at the both the edge of the talonavicular joint, but specifically through the subtalar joint. You can see clinically, most of her pain from my exam was with stress range of motion. She did have some weakening in the posterior tibial tendon. This deformity was semi-rigid, and she had equinus, as oftentimes these patients do. You know, I had a attending once who said, if you can control the Achilles tendon, you can control the world. So, you know, we see a lot of these issues where patients have that dominant force generated through the Achilles tendon, which then is creating transitional forces in the foot and some of these progressive collapsing foot deformities. So in this case here, you can see I used a single DynaClip Forte over the talonavicular joint and single screw through the subtalar joint. Nothing too dramatic here. In my traditional time doing these cases, I would have used 2 screws or perhaps a little claw plate or 2 staples. I think that the force and compression and rotational stability, as we talked about earlier, from the Forte allows me to use one device across the talonavicular joint. You know, there's oftentimes this question as to, is it okay to use a staple and a screw? Do we use them together? Does one go in first versus the other? To me, if your screw can impart enough compression dynamically through the device, then my belief would be that I could use just a staple, or I could use a staple and a screw, but I'm typically putting in the staple first because it's imparting to me a little more of that dramatic dynamic compression before I'm adding something else. You know, my thought always is, as soon as you add a screw along with that staple, you're now taking a device that was once dynamic and making it static, which is fine. It can impart increased rigidity, which again, like I talked about before, rigidity is important to decrease strain on the bone and increase that soft callus transformation to hard callus. But if I can, I try to just stick with something dynamic like staples, either and the legs of the staples functioning in harmony, I'll say, and not opposing one another. So in this case, you see, again, I just prepped the joints with simple osteotome. And this is a case where typically there'll be 4 weeks non-weight bearing. After that 4 weeks, I begin this transitional process. And my protocol for patients is a week of 75% weight bearing in a boot with crutches, a week of 50% weight bearing in a boot with crutches, then a week at 100% in their boot with crutches. And then at that point, we begin to transition them. You can see at this patient specifically, we were able to allow her to return to her work duty at the hospital 10 weeks post-op, and she was fine with that. This did again include an Achilles lengthening, but we were able to achieve powerful compression. This picture is at about 3 months post-op, and you can see on that lateral view, pretty good woven bone across that talonavicular joint fusion site. Even if you go back to the study that we talked about earlier with Ellington, it seemed to show that the talonavicular joint was one bone or one joint that did specifically well with just staple fixation versus a combination of modalities. Here is a lady, a 56-year-old female. She's a teacher. She was very active. She did a lot of high demand exercise and CrossFit and that kind of stuff. She had a history of diabetes, hypertension, hyperlipidemia, and asthma. She was a little on the fluffier side, but not significantly obese. She had this progressing pes planus deformity and weakness over the posterior tibial tendon, whereas most of her pain was actually in the posterior tibial tendon, though she did have some pain associated with her bunion and the lateral sinus tarsi or subtalar joint as well. In fact, this was bad enough to the point that she had stopped exercising altogether and was really changing her lifestyle. At that point is when I talk to patients about the idea of advancing to something more surgical once they've failed conservative management and they're noticing something that impedes on their life. So in this case, we did a translational osteotomy of the calcaneus. You see, I also did an Evans type lengthening of the lateral column. We did a flexor tendon transfer because her posterior tibial tendon was just complete crap. And then we used a single DynaClip Forte over the first tarsal-metatarsal joint to correct her bunion. So if you sort of look at the position of the foot before, you have probably 40% talar uncovering, which, you know, the Foot and Ankle International Consensus Statement came out recently, and that's a good indication for some more bony procedures. But again, you see here, good correction of that first ray. At this tarsal-metatarsal joint with just a single staple, we're able to improve rotational stability and compression across that joint. So we're limiting the amount of devices that have to go in there. That's, you know, certainly good from a hospital cost standpoint, but also from a patient standpoint. So with this case, again, 4 weeks non-weight bearing in a cast boot. We then transition them through that same post-op protocol with respect to weight bearing. And then we begin physical therapy at 8 weeks and begin getting them back to activity. This patient, 12 weeks, they're back to starting some low demand exercise. And anytime I do some of these soft tissue surgeries, I typically will keep them in like a rocket sock type brace for about 6 months post-operatively whenever they're doing really high demand stuff. This is a 21-year-old female who's a college student, avid college soccer player. She had this progressive hallux valgus deformity, a lot of hypermobility. She had attempted orthotics, shoe gear changes, that kind of stuff. And oftentimes with these patients, I tell them, honestly, you know, orthotics and all that, they're like eyeglasses. They may help you see better, but they're not going to fix the inherent problem. So in this case, she didn't have a lot of flat foot deformity. So if you look at the lateral view, not significant flat foot. So I don't need to really worry about addressing that because obviously we know that could contribute to recurrence of the bunion deformity in a high number of patients. So really, we were just focused on the bunion, which was hypermobile. And so we addressed it with a tarsal-metatarsal joint fusion. And I oftentimes will do phalangeal osteotomies because everybody wants their toe to be perfectly straight. So in this case, again, single DynaClip Forte dorsally over the joint. These patients, I do let weight bear immediately after surgery in a protected boot. We do the boot for about 4 weeks, and then gradually advance them to activity. By 8 weeks, I was letting this young lady get back into some low demand athletic activity and begin to sort of advance back into her practicing. But you can see here, this is an x-ray at 8 weeks where we see good consolidation across that tarsal-metatarsal joint and good alignment, which has been maintained despite weight bearing across that first ray.
Thank you, guys. Those are some really interesting and impressive cases. So, you know, in summary, the DynaClip Forte really is an excellent implant that allows for sustained compression. You know, we think it really has superior biomechanical properties. And when you compare it to some of the competitor staples, certainly some advantageous design differences. It's low profile, and you know, the instrumentation is really intuitive and easy to use. And there's multiple indications in the foot and ankle for its application. So I will invite any of the participants to go ahead and send in any questions that you may have, and we'll try to get through as many as we can. So I have a question for our panel, and maybe we'll start with Dr. Ritter. Zach, you certainly were an earlier adopter in terms of NiTiNOL staple technology. So can you talk a little bit about what procedures that staples have replaced your use of plates and screws?
Yeah, so, I started using NiTiNOL compression devices probably 4 or 5 years ago. It's been a while. And the first couple of cases where I started doing them, I made sure that my normal plates and screws were there because I was suspicious of the technology, because I had used previous generations of NiTiNOL technology, which were wanting. So I think once you get your hands on this and actually put it in something, you can understand the rigidity that it imparts to whatever construct. And so I often say, with specifically the Forte staples and some of the applications for staples, it's sort of like Frank's Red Hot sauce. Once you taste it, you're going to love it and you're going to want to try it on everything. I have really tried to see how I can expand indications, whether it's a first metatarsal phalangeal joint. I think that when you're getting into Liz Frank joints, it's nice to have some versatility to apply staples in different planes and across different joints. And you can really impart a lot of compression and rigidity there across tarsal joints, talonavicular joint. I've used staples for like Dwyer's or to support an Evans wedge, to do an Evans fusion of the CC joint, to do just a traditional triple. Like all of those I think work well. I've even extended use of staples into fracture management. Like instead of an interfrag screw, sometimes I'll throw a little staple to hold things in place as I'm applying my, more abundant fixation. Even some of our upper extremity guys are using them now as well. So I think there are a lot of applications. There's still some tricky areas to try and get them in, like subtalar joint. It's a tricky area to try and get it to augment a subtalar fusion. I have used it once for that in a patient with this sort of aberrant anatomy that allowed me to do so. You could add it even to ankle fusions if you're adding to the margin. I don't think it's yet designed to a point where we can use it as isolated fixation for an ankle fusion, but we can certainly use it concurrently to whatever other devices that we are using. So I think that there's a lot of application to it. It's really just dependent upon the anatomy and where you can squeeze it in.
Craig, Jeff, thoughts?
So for me, it's pretty much replaced for midfoot fusion. I pretty much use staples exclusively as opposed to plates and screws. I find it saves me a lot of time in that regard. I'm still using plates and screws for Liz Frank fixation, obviously not when I'm not fusing the joints, but for fusions, predominantly staples. Similarly with the hindfoot with calcaneocuboid and talonavicular. I've used a fair number of two-leg staples for subtalar fusion, but I agree with Zach, it's kind of hard to get it in there around the fibula. It's a little bit tricky. I have used staples for ankle fusion, in patients who maybe aren't as heavy without significant deformity. I found it works very well with a 2 or 3 anterior staples, as well as maybe a posterior crossing lag screw. I have not used it as much in fracture management, with the exception of a couple of Weber A distal fibular fractures.
I've used them a little bit throughout the midfoot for probably 4 or 5 years, and haven't adopted as much to the hindfoot. But I think the one thing, just to add to what has already been said about the staples, the one thing I've noticed with the DynaClips, the 2-time staple in particular, but even as we're extending that technology now, and some of those design elements with the Forte, it really is a pretty robust staple. With our limitations at our surgery center, we tend to have a little bit more, you have to use what we have contracts for. And we've gone through a couple of iterations of different NiTiNOL staple designs. So I've got my hands on a few of them. And I have definitely seen far fewer fractures of staples, failure of the staples. And it just seems like the design is much more robust, particularly at that corner of the leg, where, from the slides from earlier, you get that stress concentration. And some of the earlier, older staple designs that I just really have not seen that same mode or frequency of failure with the standard DynaClip staples. And obviously we'll see how the Forte continues to perform, but it's been very similar in that regard in terms of, I think, just a much more robust type of construct as far as staples are concerned compared to some of the other brands that I've used.
All right. Thanks, Jeff. Hey, we have a specific question about the MedShape staple in regards and in comparison to the Right medical staple. I have not used the Right staple. I don't know if any of you guys have, or Craig, I know you were a fellow down in North Carolina and they might have used quite a bit of Right product down there, but have any of you guys any experience with the Right staple, and how does the MedShape compare to that?
So I've only used the Right, I believe it's the quick staple, which is just a static stainless steel staple, not any form of the Right NiTiNOL staple. I will say though, just in general, when comparing the MedShape staple to the competitor staples, I've noticed an increased amount of compression and strength. And one way that I've learned that is by trying to reapply the distractor to, in the lab, trying to reopen and reinsert the staple. It takes a lot of force to re-expand that staple. It's pretty impressive.
Yeah, unfortunately, no experience with the Right medical staple here. Sorry. Yeah.
Okay. Yeah. What about post-op protocol? So, you know, I was pretty impressed with your cases about how quickly you guys are mobilizing these patients, especially with progression of weight bearing. So, can you guys talk a little bit about how the use of NiTiNOL staples has maybe changed your post-op protocols in general for most foot and ankle fusions?
I'll start on the conservative side maybe. So I've been a little bit of a slower adopter for progressive weight bearing, you know, and I came from a background that was generally a bit more conservative from a weight bearing standpoint. You know, so traditional, like a mid-foot TMT fusion, for example, I would usually keep them non-weight bearing for 6 weeks, and then slowly progress their weight bearing kind of week by week from there, to the point that they're, you know, weight bearing fully in a boot by about 10 weeks, and then getting out of a boot to a shoe by about 12 weeks. And with the staples and the compression, the stability, I've started to relax on that a little bit, to the point where, you know, as you've seen with a few of these cases, you know, some of it, the patients are going to do what they want to do, and you can only hope to contain them a little bit, but at least allowing for a little bit of touchdown weight bearing for balance in a boot up until 6 weeks. I'll let them fully bear weight on their heel if they can balance well enough that way for a TMT fusion, for example. And then at 6 weeks, just let them full weight bear in the boot to the point where once they're comfortable getting into a shoe, they can go for it. So really gets them into a shoe about a month quicker, gets them at least balancing on their foot a lot sooner. You know, and my patient population, I have a lot of older folks that, you know, when you tell them they're going to have to be non-weight bearing for 3 months, you know, they'll look at you and say, well, forget that. Let's just keep doing cortisone injections, because there's no way that I'm going to be able to help take care of myself and you know, mobilize. And, you know, can be kind of a deal breaker as far as being able to provide an operative solution that, that patients really, I won't say need, but, you know, I think would benefit greatly from, as opposed to just kind of being miserable with their cortisone injections and Voltaren gel and those sorts of things. So I've been getting a little bit more aggressive with it. I don't think to the point where Zach or maybe Craig are at this point, but, you know, that's partly where it's been great to collaborate with the team on this stuff. Because you can really see what the power of these staples are. And I think that's a huge bonus potentially with this technology, is if we can advance weight bearing a lot quicker, it makes it a little bit easier to get patients moving faster as well.
Yeah, so I did my fellowship in Italy, so I'm super cavalier. So, you know, it's, I can't say that it has dramatically changed my post-operative protocols with respect to everything. I think with respect to tarsal and mid-tarsal fusions, I'm certainly weight-bearing patients faster. For example, lapidus's, I've always weight-beared immediately. I think that to me, the key is not the immediate weight-bearing, it's the transition to full weight bearing or unrestricted activity. You know, if I'm seeing patients that are consolidating more anatomically, or I'll say faster, at their fusion sites, and I'm able to return them to activity a bit faster. So I'm seeing a much more rapid progression rather than waiting for their bone to catch up to where I want them to be. So I think that's probably the most profound impact that I've seen in my practice.
And I really have not changed my practice too much. I'm kind of a nervous Nelly and a pessimist in that regard. And I think as I think Jeff said before, it's kind of a race against time. You're racing between getting the bone to heal before the device fails. And I think any device will fail, you know, if the bone isn't healed properly. So I tend to be fairly conservative as well. I do find that if I tell a patient non-weight bearing for 6 weeks, they'll be, you know, oftentimes walking on it sooner. And I have noticed people are more comfortable with weight bearing earlier, but I have not been that aggressive to date.
Yeah. No, I agree with you guys. I think that, you know, I am starting to be a little bit more liberal and weight-bearing patients just a little bit earlier, but I'm still pretty conservative, I think. And we'll see how, you know, the years go by using the staples more. Let's talk a little bit about compression when you're doing a fusion. So, you know, I think one of the common errors that people make when they're first starting to use staples is they kind of forget about getting any type of compression across a joint, and they just pop the staple in and think the staple's going to kind of do everything for them. But you know, some of these joints can be pretty tough to try to get compression, like the second or third TMT fusion or whatnot. So can you guys just speak to some techniques that you have that to get compression before you put the staple in? Why don't we, Craig, why don't you start?
Sure. So a couple of ways I like to do it. I like when I use a Hinterman distractor to prepare a joint, I'll often put that in reverse and compress the joint through the Hinterman, plus or minus some provisional K-wires to get that bony apposition. And you've seen some of my x-rays that I also use a screw along with the staple some of the time, not all the time, and I'm getting away from that, trying to do more exclusively staple fixation. But that's the way I would achieve it initially.
Yeah, I think that, you know, there are a lot of compression distraction devices on the market now, and some of them I think work very well. So if I really need to compress a large area, I will do so. Otherwise, I think, you know, through joint prep, you can get surfaces that are relatively well opposed, and then I'll apply, you know, all 170 pounds of pressure here and really crunch it down, and then use just provisional fixation with the wires. So I'm getting sort of my more mechanical compression directly through my force, and then adding that dynamic compression of the implant, which just sort of adds upon that.
Yeah, I don't know that I'd have much to add to that. You know, I will actually, I can't say that word tonight, axially load TMT joints and you know, navicular cuneiform, that sort of thing, kind of from the end of the foot with putting the staple in. So still just kind of brute force approach. But a little bit to the point with like the biologics question, especially the TMT joints, I do want to make sure that there's adequate compression coming across, or adequate bone contact coming along with that, even if you're not getting a lot of external compression before you apply the staple. So I do use bone graft in a lot of these fusion cases. Almost every midfoot or hindfoot fusion, I'll add some sort of biologic. You know, my preference is calcaneal autograft. It's easy to harvest. You don't need much. And, you know, I think just getting a little bit of that cancellous bone, even in older patients where you may not be necessarily getting as much of an osteogenic effect from it, just having a little bit of that conductive framework and ensuring you have good bone contact across the fusion site, I think hopefully supports a little bit of that with the compression.
Yeah, you know, I think this question about biologics is interesting. You know, using the NiTiNOL technology hasn't changed the biologics that I use. You know, I think that biologics I choose are based more on, you know, the host and comorbidities, but has NiTiNOL changed your use of biologics now that you're getting more compression from your implant? Zach, Craig?
I don't think so. I think that, you know, I still sort of risk stratify my patients as to who I think needs a biologic versus not. And certainly it's procedure specific, but also patient specific. But I can't say that using it has dramatically changed my use of biologics.
Same here, same answer.
Okay. If there's no other questions from the audience.
A couple points, John.
Yeah.
I think one thing to consider is you might get an occasional patient with really bad bone, and I still have concerns about using staples in some cases with really poor bone where it's going to just kind of compress right through the bone. So something to bear in mind that I think the staples are phenomenal for most applications, but you know, nothing's 100%. So it's important to have, you know, have other options at your disposal in those situations. And the second thing was regarding the, you know, using a screw and a staple. I think Zach's point is well taken. When I have used a screw in the past, it's been a partially threaded screw. And so my belief is that if that's put in first and a staple on the top of it, I don't think the screw will block your dynamic compression. If anything, it'll kind of compress around the screw. I don't think you lose a whole lot there. I don't really have any data to back that up. But that's just my working theory.
Any other thoughts, guys?
Yeah, I've seen staples, to Craig's point, pull through bone in some pretty osteopenic patients. Specifically as you move further forward in the foot, like first MTP joint is where I've seen it the most. So I think that's probably one of the good things specifically with this is that 30 millimeter staple does allow you to expand your legs a little further back from the actual joint site. So theoretically, there's a little more bone to abut that and prevent that sort of pushing through.
All right, great point. All right, guys. Well, it doesn't look like we have any more questions. So I want to thank Dr. Seybold, Lareau, and Dr. Ritter for all your thoughts on this, and enjoyed being on the design team with you guys. And I want to thank MedShape for hosting us. And everyone have a good night. Thank you.
Thank you.
Thanks, everybody.